Hey guys, Miss Hill here, and we are going to be talking about individual module 6 today. Specifically, we are going to be talking about newborn care, and this is PowerPoint 1 for individual module 6, lecture 1. So here are your learning outcomes, again, same as your book. So for newborn care, in terms of testing purposes, you need to be very familiar with the Ballard scoring tool. You need to understand the APGAR assessment and be able to apply that. And you need to know your newborn reflexes. We won't go over those things in depth in this PowerPoint, but they are all things that you should be familiar with and have knowledge of. So a quick little overview about newborns. The newborn period is the time that occurs from birth through the 28th day of life. During this time, newborns are also referred to as neonates. And during this period, the newborn adjusts from intrauterine to extrauterine life. So there are so many systems in the body that undergo changes so that they can now go from depending on placental perfusion and mom's nutrition to being their own person. There's a transition from that fetal standpoint to the newborn standpoint, and it is the most complex physiologic adaptation that happens in the entire human experience and involves almost every single organ in the body. So you can imagine that this time frame through which they make this transition really needs a lot of oversight, and they need very close care and supervision. So what happens in these adaptations? There's a neonatal transition in the first few hours of life when the newborn's body systems start to adapt to being outside of mom. Most significantly, the respiratory and the cardiac systems undergo some very dramatic changes within the very first few minutes after birth. And we're going to talk about those in depth. So the respiratory system has to go from here to here. So these guys are going from being dependent on the placenta to being able to perfuse and oxygenate the lungs. To be successful, this respiratory transition must include lung expansion and pulmonary ventilation, and there must be an increase in pulmonary circulation for all of this to occur. So the newborn has to immediately establish respiratory gas exchange. At the same time, all the circulatory changes are happening as well. So for the initiation of respiration to occur, inspiration and expiration begins typically with the first cry, and lung fluid becomes reabsorbed. Not totally, but for the most part. And the reabsorption of the fluid that was in their lungs, filling their lungs, because remember, they are in utero, they are swimming in a lot of amniotic fluid, and all of that is in their lungs. So to be able to breathe once they're born, all of that fluid has to go somewhere. It either has to be squeezed out or it has to be reabsorbed. So we can't squeeze out fluid that is buried deep in the alveoli. That fluid has to be reabsorbed by the body, and pressure changes help this to happen, plus surfactant. So let's go through this little list. So for lungs to function immediately after birth, pulmonary ventilation has to be established through lung expansion. If the lungs do not expand, then breathing cannot occur. There also has to be a marked increase in pulmonary circulation. So in utero, circulation does not occur in a great amount in the pulmonary system. Remember, we have the shunts, and that blood is shunted across to the left side of the heart instead of perfusing the pulmonary system. But once the baby is born, pulmonary circulation has to increase dramatically because now our lungs have to work. So we have to have pulmonary ventilation, which happens because the lungs expand, and we have to have pulmonary circulation that increases in order to sustain lung function. So in utero, fetuses practice this ventilation and breathing movements. Remember when we talked about the biophysical profile and how part of the scoring of the biophysical profile are breathing movements. So they practice doing this in utero. The first breath of life will initiate a serial opening of alveoli. So think about So I like to think of it as as kind of like that bubble wrap that you get that you can wrap things in that so they won't get broken. So when you get a package in the mail and it's fragile, it might come wrapped in all that bubble wrap. If you step on it, all those bubbles will pop and one at a time. But think about that in the opposite way. What about whenever that bubble wrap is made in the factory? All those little bubbles have to be blown up, right? There's probably some type of serial event that happens that makes that bubble wrap. All those bubbles pop up across the wrap, and alveoli kind of do the same thing in utero. As the baby takes that first breath, there's a serial popping open of alveoli. They expand themselves. And once that happens, fluid becomes reabsorbed. So the amniotic fluid they had in their lungs will start to reabsorb itself into the body and move outside of the alveoli because we need those open with air in order to ventilate. After the first inspiration, the newborn exhales also with crying, and that creates a positive intrathoracic pressure. So everybody take a deep breath and exhale. When you do that, there's a positive intrathoracic pressure that occurs, and we need that in order to be able to ventilate appropriately. With every breath that happens after that, the lungs continue to expand and the alveoli walls continue to stretch, which helps to increase the volume of air in the lungs. All of this expansion and stretching that occurs helps that lung fluid move into the interstitial tissue and space. It might take hours for some of that fluid to move into the appropriate places. So when you listen to a newborn's lungs right after birth, if all of that fluid has not moved out, you might hear they might sound a little junky. And that's okay, as long as they're ventilating well. There must be a functional residual capacity present as well. And that pulmonary, yeah, let's not go there. I don't want to do that. Let's talk about those some of the infants that might not do this so well. Um, because this is such an important process, it's important for nurses to understand who is at risk for not moving through this adaptation easily. Your small for gestational age infants, they might not do this very well because they have an immature musculature. So they have a hard time with um, chest wall compression and expansion. If their muscles aren't so, and premature babies too, if there's no um, if there's not the ability to expand the lungs very well, that requires musculature to do that, then that puts them at risk for not being able to move through this adaptation maybe as nicely as a normal newborn. So you're small for gestational age babies. Your C-section babies sometimes will not initiate respiration quite as well because they don't go through the chest wall compression that happens in a vaginal delivery. Also, your babies who have been exposed to maternal drugs that can cause respiratory depression, and babies who are uh, meconium babies. They may have meconium in their lungs, and that may hinder their ability to move through this adaptation well. By 30 minutes of age, most newborns will have a normal functional residual capacity um, with their lung expansion. And problems that occur when fluid isn't cleared from the lungs, we could be looking at kids who have an underdeveloped lymphatic system. So it could be some type of developmental issue, genetic problem, or kids that have had a complication before or during labor that interferes with lung expansion. There might also be different types of chemical factors that contribute to the onset of breathing. So babies who had um, some type of hypoxic event in the labor period. Maybe there was a nuchal cord around the neck and that caused some asphyxia. That's abnormal and that could depress respiration. Um, Early cord clamping before initiation of respirations may result also in bradycardia as well. So what this means basically is that if the cord is clamped before the baby takes its first breath, then the baby might brady down, and if the heart rate is low, they're not going to start taking those respirations like you would expect. Also, cold temperature compared to the intrauterine environment stimulates the nerve endings, and the newborn will respond by kind of holding their breath. Um, so, if you can think of yourself as getting out of a shower or think of yourself as jumping into a cold body of water. So jumping into a pool in the middle of the winter time. It would take your breath away, right? You would be super cold. Now, this is not how cold they are whenever they come out, but it's still a massive change in temperature. They've been inside of mom in a nice warm fluid for months, and now they're being birthed into a very cold environment. Think about the babies who are born in the OR. Those babies are in an extremely cold environment, right? Because we keep the air in the ORs very, very cool. So those babies might be a little more cold stressed than your others. So making sure they're getting nice and dry. Um, is very important. I want to go back to functional residual capacity for a minute and make sure that you understand what that means. So functional residual capacity is something that we all have from a respiratory standpoint in order to keep our alveoli open. If we did not have functional residual capacity in our lungs, our alveoli would collapse on expiration. So whenever we exhaled, our alveoli would totally collapse down. So that's one reason why functional residual capacity plays a big role in newborns because we want those alveoli to stay open in order to ventilate the lungs and perfuse the blood with oxygen. And if there is no functional residual capacity there, those alveoli will collapse and prevent that from happening. So, initiation of respiration can be helped with stimuli that help respiration to begin. So if you notice, if you've ever seen a baby born, the nursery nurse dries that baby off vigorously. We rub them very vigorously. So we use tactile stimulation. Babies also can hear. They have visual stimuli, bright lights, and all of those things. That helps respiration to begin. It's a shocking experience. Joint movement also will enhance the initiation of respiration. Being thoroughly dried and placed on the mom for skin-to-skin contact also helps with respiratory efforts as well. And things that will hinder the initiation of respiration are a contracting force between the alveoli. So if the alveoli are trying to stay open, but there's something that is preventing them from doing that, say a lack of surfactant, that can hinder the initiation of respiration because those alveoli cannot pop open and stay open. The viscosity of the lung fluid. Meconium is really sticky, yucky stuff, and it smears very easily. And because it's so sticky, if that is in the alveoli and those alveoli are trying to pop open, think about putting a piece of gum, a chewed gum, in your hand and then trying to open your hand up. It just will stick and start to spread, right? It will be difficult possibly to get your hand open without that gum smearing everywhere. So that can prevent initiation of respiration. And also the ease with which the lungs are able to fill with air. So premature babies have very, very stiff lungs. Their lungs are not what we call pliable. Something that's pliable is easily stretched or easily expanded. So I think of that like Stretch Armstrong toy that my husband had one whenever he was really little, and you could stretch that thing for days and days. It was a very pliable toy. Lungs have to be pliable in order to ventilate themselves and to ventilate the body. And so if the lungs are not able to fill easily with air because they're stiff, then it opposes the initiation of this respiratory adaptation. And stiff lungs don't have to just occur with premature babies. There can be other types of disease processes that factor into that as well. So what's the physiology of this all? From a cardiopulmonary standpoint, we'll just run through this kind of quickly. As air enters the lungs, there is an increase of PO2, and that stimulates a relaxation of the pulmonary arteries. it triggers a decrease in pulmonary vascular resistance. Okay, so pulmonary vascular resistance in the fetus is high because we don't want all of the blood going into the pulmonary system. So if pulmonary vascular resistance is high, then the blood will shunt to the left side of the heart in the fetus. But whenever the baby is born, that pulmonary vascular resistance has to decrease substantially because now we want blood to go there. So you think of this from a pressure standpoint. If something has a lot of high pressure, it's going to be difficult for another substance to enter that area of high resistance. But if we decrease the pressure in that area, then we can more easily force something into that space. So that's kind of what pulmonary vascular resistance is doing. So in order for all the physiology of this to work, pulmonary vascular resistance in the newborn has to decrease with that first cry. Vascular flow into the lungs will increase rapidly once pulmonary vascular resistance decreases. And then around 24 hours time, newborns can achieve 100% normal lung flow. The blood is distributed throughout the lungs, and the alveoli may or may not be fully open. Remember, it's a serial opening of alveoli. The heart must deliver enough blood to be functional and to open the alveoli as well. Shunting of the blood is really common still in the newborn period, so it may divert away from the lungs, especially if pulmonary vascular resistance does not decrease. And if this happens, it can be responsible for an unstable transitional period and respiratory function in the baby. So we have to watch them very closely, particularly, and think about this from an assessment standpoint, from a nursing assessment standpoint. Sometimes it's not just enough to understand the physiology of things, but how does that physiology of the system manifest itself in a way that you can assess it? So the shunting of that blood, how would you assess that? Well, you would hear murmurs, right? If blood is being shunted and it's a turbulent flow, you're going to start to hear heart murmurs. And it's okay to hear some transient heart murmurs in the newborn, but if you heard that, you would want to really be cognizant about reassessing that kid every few minutes, because if you understand the physiology and you know that shunting of blood can divert, that blood can be being diverted away from the lungs, then it can affect the respiratory system for that newborn, and things could not go so well. Transportation of oxygen also occurs with respiratory adaptation, and has to sustain life. It depends on the type of hemoglobin in the red blood cells. So we have fetal hemoglobin, and that has a affinity for oxygen than adult hemoglobin. 70% of the hemoglobin in the fetus is newborn. And a high concentration of oxygen in the blood makes hypoxia difficult to recognize in the newborn. So sometimes you don't see things till the oxygen level is already low. So said in another way, fetal hemoglobin is mainly what the newborn has. And fetal hemoglobin has a greater affinity for oxygen, meaning it carries more than an adult hemoglobin does. So because the fetus has a really high concentration of oxygen in those red blood cells, it makes hypoxia difficult to recognize in babies. So you don't see signs until the oxygen level is already low. So in terms of maintaining respiratory function, the lung's ability to maintain oxygenation and ventilation is influenced by lung compliance, or pliability is another way to say that, and airway resistance. So here again, your pulmonary vascular resistance. So lung compliance has to do with the elastic recoil of the lung tissue, and there are differences in the newborn when compared to adults. So newborns have a reduced lung space, and they have a really limited space available for lung expansion. Their chests are small and their hearts are large. So their lungs do not have but so much room to be able to expand. Plus, if there is no elasticity to allow that lung tissue to recoil, then exhale becomes difficult. Increased airway resistance in the newborn also is a factor. Their airway resistance is much greater than that of adults. So what do we see? What are the characteristics of newborn respiration? Initial respirations are largely diaphragmatic. They're shallow. They are irregular in depth and rhythm. So if they are diaphragmatic, that means the diaphragm has to be there and be functional to allow this to happen. So if they have some type of anomaly with the diaphragm, if they have a diaphragmatic hernia, those things will quickly manifest themselves, and you will end up with a hypoxic newborn and some severe respiratory complications, because we need that diaphragm to help with respirations. Periodic breathing is okay. So newborns have periods of apnea, and it's normal for those periods to last anywhere from 5 to 15 seconds. If those periods of apnea start lasting longer than 20 seconds, they need to be further evaluated, because that is abnormal. It's okay to see those periods from 5 to 15 seconds. When newborns cry, and probably all of you have seen it one time or another and maybe just not recognized what it is, but when newborns cry, especially when they get very upset, so think about if any of you have seen a brand new newborn baby get a bath. They scream bloody murder, and a lot of the times whenever they get so worked up like that and they're crying so hard, you will watch them they'll hold their breath. It appears like they're still crying, but they hold their breath for so many seconds, and sometimes 15 seconds is a long time. So we just watch those things, and if those periods of apnea become greater than 20 seconds, we report that and we watch them much more closely. Newborns are also obligatory nose breathers. So if they have anything that is obstructing their nasal passage, such as fluid, meconium, mucus, that can cause respiratory distress for them. Breathing through your mouth is a learned behavior. You don't come out knowing how to do that. You learn how to do that. So newborns don't have the ability to be a mouth breather. We got to keep their nasal passageways clear. And another reason why it's very important when you do your head to toe assessment on a newborn to ensure that their nasal passageways are patent. Newborn rates of respiratory rates are normal, anywhere from 60 to 70 breaths a minute, and that's normal immediately after birth and for the next 2 hours. And then we see it drop off to somewhere between 40 and 60 breaths a minute. But initially, they're trying to ventilate. They have a need for oxygen, so their breathing may be a little increased. Some signs of cyanosis are okay for the newborn. Talking about acrocyanosis, meaning the hands and the feet, and that's normal for the first several hours after birth and can even still occur up to a couple of days at times whenever they get cold, like when they're getting a sponge bath or maybe when they're getting undressed. When they're crying, you might see acrocyanosis show up for a couple of days after. Respirations less than 30 breaths a minute or greater than 60 breaths a minute at rest. So I told you guys 40 to 60 because that's what I'm used to, but I guess your book is using 30. Um, so 30 to 60 we'll go with as normal from your book standpoint. So anything less than 30 or anything greater than 60 when a newborn is at rest should be watched closely, especially if it is accompanied with nasal flaring, grunting, or any type of retractions. That should be reported immediately because those three things, flaring, grunting, and retractions, are telling you that your newborn is struggling. Newborns also may sneeze. Remember, we said they were obligatory nose breathers, and that is okay if we're talking about one or two sneezes here or there. But if a newborn has excessive sneezing, they're sneezing over and over and over again, that is not normal, and that can indicate that they are going through some type of withdrawal. So you would start thinking, wonder what the mom has been using. Um, because that indicates withdrawal from a substance. Okay, let's try to get through the cardiovascular system. So from a cardiovascular standpoint, the fetus has to move from fetal circulation to normal extrauterine circulation. So these shunts that the baby has had in the heart now have to close up so that we can start perfusing the lungs to support respiratory adaptation. The shunts will close due to circulatory pressure changes, and they close transiently. So they won't, some of them don't close for hours to weeks after the baby is born permanently. So there may be times whenever there's a murmur present and times when it's closed and there's no murmur. 90% of the murmurs that you do hear in newborns are transient, meaning that they will correct themselves. They will eventually permanently close and there won't be uh, any murmurs anymore. 10% of those that don't close, part of that population will show signs and symptoms and may have trouble, and part of that 10% may never even know that they still have a little opening. It depends on the severity. So from a fetal newborn transition standpoint in regards to the cardiovascular system, that first breath that expands the lungs decreases the pulmonary vascular resistance, and that increases pulmonary blood flow. So instead of the blood being shunted, now that decrease in pulmonary vascular resistance is going to allow the heart to pump blood to the lungs. So the pressure in the left atrium increases and the pressure in the right atrium will drop. So those pressure changes have to do with closure of the shunts. Systemic vascular resistance increases when the cord is clamped. Okay, so think about it this way. if you are perfusing from the placenta through the umbilical cord to the baby, you have to have a low resistance for that blood to get from the placenta to the baby. And the baby has to have a low systemic vascular resistance to allow the flow of the blood from the placenta through the umbilical cord into its body. But once that cord is clamped, the baby has an increase in systemic vascular resistance. So it's just like kinking off a water hose. While the water hose is not, if you're watering plants and your water hose is all coiled up, and you've got great water pressure and you're able to water all your plants nicely, but then someone comes along and kinks your cord off, kinks your water hose off at some point, it's going to decrease the flow that's coming out one end. But the other end, there's going to be an increased pressure. So it's the same concept. There are 5 major areas of change that occur from a cardiovascular standpoint. These guys get an increased aortic pressure and a decreased venous pressure. They have an increased systemic pressure for the reason we just said. The cord becomes clamped and increases that systemic pressure, but they have a decreased pulmonary artery pressure. They have a closure of the foramen ovale, closure of the ductus arteriosus, and a closure of the ductus venosus. The foramen ovale will close somewhere between 1 to 2 hours after birth, and then it'll close permanently around 30 months. The ductus arteriosus will close 10 to 15 hours after birth, and it will permanently close in around 4 weeks. It turns into the ligamentum arteriosum after closure. The ductus venosus happens with cutting of the cord or clamping of the cord, and there's an anatomical closure in about 2 months. The neonatal non-pathological heart murmurs that you can assess as a nurse is caused by incomplete closure of the ductus arteriosus in the foramen ovale. So how do we evaluate if these adaptations are occurring appropriately? From a nursing assessment standpoint, you're going to be checking heart rate, blood pressure, heart sounds, cardiac workload, and that will provide you with enough information to evaluate whether the cardiac function is appropriate. Blood pressure is the highest in newborns immediately after birth, and then it will descend to its lowest level around 3 hours of age. By days 4 and 6, the blood pressure rises a little, and then it'll plateau at an appropriate level after that. Peripheral perfusion pressure is very sensitive in newborns, and it's an indicator of the newborn's ability to compensate for alterations in blood volume before changes in blood pressure. Values in the first 12 hours will vary based on birth weight and gestational age. A kind of a good rule of thumb is that their mean arterial pressure should be equal to or very close to their gestational age. 2-point pulse oximetry is recommended to screen for congenital heart disease. And so what this means is that you want a pulse ox in 2 different places. In newborns, we like to check the pulse ox on the right wrist, and that tells us what their preductal oxygenation status is. Everywhere else that you check it gives you a post-ductal O2 sat. If it's less than 95% in 2 points, we need to refer them to a cardiology clinic because they may have some type of congenital heart anomaly. Average resting heart rate in the first week of life is somewhere between 110 and 160 beats, and it can vary pretty significantly based upon their activity or based upon the period of reactivity that they're in. So when they're in awake and active states, their heart rate can be much higher than when they are during a deep sleep state. So murmurs are something that we hear a lot in newborns. And again, those are produced by turbulent blood flow through shunts that have not either closed completely or abnormal shunts that have formed because of a congenital heart anomaly. Blood flows across an abnormal valve or a stenosed valve. It can be from an atrial or a ventricular standpoint in terms of septal defects. Um, Flow across normal valves will become increased. And again, 90% of them are transitory and will fix themselves and not associated with anything bad. But the other 10% really need to be referred. So we don't know which group falls into the 90% and which group falls into the 10%. So we watch all of them closely if we hear any type of murmur. All with the transitory um, heart murmurs, you might also hear a click towards the left lower sternal border. And the click that you hear is just that shunt closing some of the time and then opening when blood flows. Murmurs sometimes are absent even in babies who have some serious heart anomalies. So that's why we don't rely on murmurs solely to try to diagnose some congenital heart anomalies, because some heart anomalies you won't hear a murmur at all, but you see other signs and symptoms. The left ventricle in the newborn has a significantly greater increase in volume than the right ventricle after birth. And that can explain why some of the right-sided heart defects or congenital heart anomalies are better tolerated than the left-sided ones. Typically, your babies who have left-sided heart defects will become symptomatic very, very quickly. Those left-sided ones are much easier to recognize, and you'll see clinical manifestations of those way before you see the right-sided one. And so the theory is that because the left ventricle has a significantly greater increase of blood volume than the right ventricle in a newborn, that's why we see the manifestations so differently between those types of heart anomalies. All right, so let's talk about blood adaptations. In the first days of life, the hematocrit may rise above fetal levels. And by 1 week of age, the peripheral hemoglobin is comparable to fetal blood counts. So there's a physiologic anemia of infancy that happens sometimes because there's a decline in hemoglobin over the first couple of months of life, but they initially they have this sort of high hematocrit. Leukocytosis is a normal finding in newborns. They've been through the stress of labor and birth. So, for the same reason that you see a maternal level of increase, you see the same in the baby. Um, from a blood volume standpoint, approximately 5 milliliters per kilogram for a term neonate is what is normal. But there are a whole lot of factors that contribute to this, and it varies based on the amount of placental transfusion during the delivery of the placenta. It depends on how long we delayed cord clamping. Was there a normal shift of plasma to the newborn's extravascular spaces? It depends on gestational age, whether there was a prenatal or a perinatal hemorrhage, so your abruptions or your previas that might have started to hemorrhage, and also blood sampling. So newborns only have about a cup of blood in their body, and that's not very much. Um, I mean, we make 1 cup of rice with 2 cups of water, right? And so babies only have 1 cup of blood around about. So taking big tubes of blood from them depletes their volume. So we don't do that. We use heel sticks and get the least little bit that we can. Now, if you've got a baby who's sick, you might need a little more than what you can get from a heel stick, but we still don't draw those big, huge adult um, tubes of blood. Red blood cells. Oh, sorry, y'all. Had to yawn and stretch. I hope I'm not boring y'all that much. Red blood cells have a lifespan of around 80 to 100 days in infants, and they don't make red blood cells as quickly as adults. So, as their red blood cells die off, if they're not making them or if they're broken down, they're not making them quickly enough. That's one reason why we can see some anemia as well. All right, temperature regulation. So, newborns need to be kept at a neutral thermal environment. And what that means is that it doesn't mean that it's 78 degrees in the room. It doesn't mean that mom is comfortable. It doesn't mean that we keep the temperature between 78 and 80 degrees. A thermal neutral environment is very individualized and it differs with every kid. So every newborn needs to maintain a neutral thermal environment for themselves. And that means that the rate of their oxygen consumption and metabolism are at the lowest point in order to sustain themselves in a uh, homeostasis, basically. So they can control their internal body temperature at the lowest rate of oxygen consumption and metabolism possible for their body. Newborns require higher environmental temperatures to maintain a neutral thermal environment. So it's a very individualized thing when we talk about neutral thermal environments. Thermoregulation is really closely related to the rate of metabolism and oxygen consumption. So newborns experience this type of triad of things that happen in relationship to temperature. They can experience hypothermia, they can experience hypoxia, and hypoglycemia. And those 3 things are so closely related in the newborn that a mess up with one of those can occur a problem in the other 2 areas if it's not caught quickly and fixed. Newborns have a thinner epidermis or thinner skin. Their blood vessels are closer to the skin. They have a nice flexed posture, but they don't shiver. So they lack the ability to warm themselves up by shivering like grown-ups do. Their flexed posture uh, keeps them warm because it reduces the amount of body surface area that is exposed. So that nice little fetal position, you think about yourself whenever you lie down in the bed at night on a really cold night, or if the fan is blowing, you put your blankets on and you ball up in a nice fetal position. It helps keep you warm. That's why a flexed posture is part of why a flexed posture is important for newborns. Their blood vessels are really closer to the skin, so they lose heat easier, and their epidermis is much thinner, so they lose heat more quickly. Um, Newborns have a really large body surface area in relation to mass, which puts them at risk for complications with keeping their temperature um, up. They have a really limited amount of insulating subcutaneous fat like you and I have, so adipose tissue. They lose heat 4 times um, more than adults. So they lose 4 times more heat than adults do because of some of those factors. So minimizing heat loss for these guys is essential. Newborns have a few different ways that they try to increase thermogenesis, or keeping their temperature up, and they use their basal metabolic rate. They use muscular activity and non-shivering thermogenesis, which is use of brown adipose tissue to provide heat. Shivering again is rare in the newborn, and if you see a newborn that's shivering, it means that their metabolic rate has already doubled, and it does very little to produce heat for them. So from a metabolism standpoint, they use their basal metabolic rate and they use this brown adipose tissue in order to create thermogenesis so that they can generate heat to keep their temperature up. But brown fat is super available and in greater concentrations in a newborn, and it's very quickly metabolized. So if they don't have enough brown fat, sometimes their metabolic compensation for temperature regulation is going to be decreased because they don't have any brown fat to help them with this non-shivering thermogenesis. Keeping the newborn warm promotes also normal oxygen requirements, and chilling them can cause signs of respiratory distress, and here is why. Remember, I talked about the triad: hypoxia, hypothermia, and hypoglycemia. So being cold and increasing your metabolic rate in order to keep yourself warm burns energy. It burns up your energy stores. And if your body is working hard and burning a lot of energy, it needs oxygen to make that process work. So as your basal metabolic rate increases, so does the need for oxygen consumption. So as a newborn increases their basal metabolic rate to keep themselves warm, they also, at the same time, are having to increase their oxygen consumption. And if they can't do that, then they become hypoxic because their respiratory system can't keep up with the demand of their metabolic system. So now we have a newborn who's hypothermic, cannot compensate, and now they've created a hypoxic environment for themselves as well. Well, also burning up all of their energy and all of their glucose stores and all of their brown fat trying to keep themselves warm will also deplete their glucose stores and cause them to become hypoglycemic as well. So that's kind of how they work together. Size and age can affect the newborn's establishment of that neutral thermal environment. Small for gestational age newborns have much less adipose tissue. They are hypoflexed, meaning they're not quite as flexed up in the fetal position. So more of their body surface area is exposed, and they require a higher environmental temperature due to that. Larger and well-insulated newborns may be able to cope with lower environmental temperatures because they have more fat stores, and if they're well insulated, they have enough fat to burn up in order to keep themselves warm. And also they're insulated. Newborns are also at a disadvantage in maintaining normal temperature um, because of what we talked about on the last slide. They have a large body surface area in relationship to mass. So they're big people compared to their weight. And they have a really limited amount of subcutaneous fat. They have much more brown fat instead. Because they are poor thermal regulators and because they are very prone to heat loss just because of the way they are developed, it's really important for us as nurses to minimize heat loss and teach the parents ways that they can minimize heat loss as well. So why should we be concerned about hypothermia in the newborn? And the basic answer to that question is because anytime there's an increase in oxygen demands, it can lead to hypothermia and eventually respiratory distress. Keeping your newborn nice and warm helps to promote normal oxygen requirements, which also will help the respiratory system during this adaptation period to extrauterine life. A couple of kind of interesting things to note. Demerol has the ability to slow or even prevent metabolism of brown fat in babies, and it can lead to a greater risk of hypothermia. So your moms who have been in labor and received Demerol and Phenergan for pain control, it's important for your nursery nurse to know that, because if that Demerol is left in the baby's system once it's born and it hasn't metabolized itself out by the time the baby is trying to adapt to extrauterine life, that Demerol can slow down or even prevent the newborns from being able to metabolize their brown fat, and it will put them at risk for hypothermia. Also, with moms who are drug users or moms who have received narcotics during labor, if those narcotics are still on board whenever, or drugs are on board whenever the baby is born, they can actually prolong and the hypothermia itself can actually prolong and potentiate effects of some of those analgesics and anesthetic drugs that we give, or even ones that mom have taken, like illegal ones. All right, so let's talk about the liver. In the newborn, the liver is a really big organ. It occupies about 40% of the abdominal cavity. So you can most always palpate a newborn liver. Um, from an iron standpoint, we know that the liver stores up iron, and as red blood cells are destroyed, iron is stored in the liver until they're needed to make new red blood cells. And how much iron is stored up in the newborn is determined by the total hemoglobin content and the length of gestation for the baby. If the mom has had some adequate iron intake during her pregnancy, typically that baby has enough iron stored up to last about 5 months. So think about red blood cells and what I told you about those. They last for about 80 to 100 days in newborns, but newborns don't make new red blood cells as quickly as an adult does. So this iron comes in really handy, and having enough of it stored up um, helps your newborn. If they don't have enough stored up, then you start running into problems. Carbohydrate metabolism is different also in newborns at term. Their carb levels and reserves are pretty low. They don't store up carbs like we do. So 1/3 of their carbs are in the form of liver glycogen, and their glycogen stores are twice those of adults. Newborns consume fuel at a much faster rate than we do of grown-ups, than we do as grown-ups. So they don't have enough stored up. So you can see why they would run out much more quickly. So it's important to assess a glucose level on admission, and if risk factors are present, or per your agency protocol, they're all a little different. So if you notice that your newborn is jittery, you want to be checking a blood sugar. If you're noticing signs of hypoglycemia, you need to be checking a blood sugar. And when this says assess glucose level on admission, that means basically sometime after birth. There will be different protocols for different hospitals in terms of how frequently, how soon you have to do it after birth, if at all. Okay. All right. Adjust myself in this chair here, y'all. All right, so let's talk about bilirubin, because bilirubin is an important thing to have an understanding of whenever you are taking care of newborns. Bilirubin is basically what is broken down after a red blood cell is pulled apart by the body system. So if you look at this picture, it's the red blood cell life cycle. And what happens is red blood cells start to form in the red bone marrow or erythrocytes. And this is called erythropoiesis. And those red blood cells are then released and they circulate in your bloodstream for about 120 days. And once it's time, once they've used up their lifespan, something in the liver called phagocytosis in the liver and the spleen will help break down those red blood cells, and they break down into a couple of different parts. They break down into the heme, or heme, I'm not sure how you say that actually, and into globin. And then in the fourth step, the heme components of blood are then recycled. So they're broken down into bilirubin, and bilirubin is excreted in the bowel. And then they're also broken down into transferrin, and that's transported back into the bone marrow. You don't have to really worry about that, but it's the bilirubin part that is important, because newborns are not able to excrete bilirubin like grown-ups are. So unconjugated bilirubin in the fetus is excreted through the placenta. The placenta does that job for a fetus. But after birth, the newborn's liver has got to learn how to do this, learn how to conjugate it and get rid of it. After a bilirubin is conjugated and bound back together, it can be changed back to unconjugated bilirubin, and that happens through a certain type of circulation in the liver. But recycling bilirubin is important because once it builds up in the bloodstream, or being able to excrete bilirubin is very important because once it builds up in the bloodstream, it can start to cause problems in the baby. Bilirubin is a yellow lipid, and if it's not excreted in the newborn starts to turn yellow because it's a yellow lipid-soluble pigment. So your newborn will start to show signs of jaundice. You might see yellow in the whites of their eyes. Their gums or their mucous membranes might have a yellow tinge to them. You'll be able to notice something called icterus. And icterus is a yellow undertone to the skin. So when you blanch out an area of the baby's skin, instead of it becoming white, or a paler color like it would on your normal person, you will have a yellow undertone instead, and the term for that is icterus. Newborns who have a reduction in their liver activity, they have large bilirubin loads, and their liver has a decreased ability to conjugate that bilirubin. Those individuals are at an increased susceptibility for jaundice. And if we can't get rid of the bilirubin that is stored up in their blood, they can end up with crystallized areas in their brain of that bilirubin, and they will end up with brain damage, which is called kernicterus. From a coagulation standpoint, babies are vitamin K dependent. They need vitamin K in order to be able to clot. So, our body has a lot of different ways that we coagulate, but most of those have to do with different types of clotting factors that we have. So, there are several types of clotting factors that are dependent on vitamin K, but newborns have a very low level of vitamin K. So they need a shot of vitamin K, and we give it intramuscularly, and they need it after delivery in order to be able to clot appropriately. Their vitamin K levels will rise slowly from a low point at 2 to 3 days after birth. But coagulation factors will not actually approach adult levels until they're about 9 months of age. I don't really care that you know all of these different clotting factors and where they come from and exactly what they do. The biggest thing to understand is that vitamin K levels in a newborn are very low, and that clotting factors depend on vitamin K. So if the newborn doesn't have any, then they have trouble clotting. So we give it to them at birth, and then they'll develop it after time. Bleeding problems in a newborn are very rare. It doesn't usually happen. But we give this vitamin K as a prophylactic in case there is some type of bleeding problem that does occur. So think about your baby who has an elective circumcision. If we didn't give that baby vitamin K, he would have a very difficult time clotting off around the circumcision site. Not to mention that we've just clamped off two arteries and a vein that lead directly into their circulatory system. So if for some reason the clamp comes off of that cord, they need to have the ability to clot pretty quickly. Um, okay, guys, I got to cut it off here because I have a phone call at 11 o'clock that I'm required to be on. And so I'm going to cut it short, and I will pick back up and try to finish this lecture up in lecture 2. Thanks for listening.